Hi, everybody. I'm Connie Rao from FHNN, and I want to welcome everybody here today, including our friends from Little Falls Village, Margaret Walker and Doran Flowers, if he's on the call, most especially. This program is the first of what will be a four-part series that FHNN is undertaking this year with regard to Alzheimer's and other dementias. This is National Alzheimer's Month, so I think it's particularly appropriate that we start today in this month after we hear from Marty and learn the basics of what this is all about. The next presentation will be by someone with dementia who does a presentation called Dementia Man that everyone will enjoy, I think, and that is going to be in January at the Willoughby. So with that, I'd like to turn it over at this point to Kathleen McGinnis. Thank you so much, and thank you again for coming.
Thank you, Connie. Thank you, Louise. Good morning, everybody. Good afternoon. My name is Kathleen McGinnis. I'm also a member of Friendship Heights Neighbors Network, and it's my pleasure to introduce Marti Brown Bailey, whom I've known for about 7 or 8 years. I became a member of Sibley Senior Association when my mother was a frequent flyer at Sibley, and I highly recommend the organization. Anyways, Marti is the director of Sibley Senior Association and Community Health at Sibley Memorial Hospital. She is also president of the Board of Governors for Seabury. So clearly she's a busy woman, and we're very grateful that you've taken time out to be with us today, Marti. Marti's an experienced speaker and facilitator who specializes in Alzheimer's and other forms of dementia, community health, and caregiver support. Marti is dedicated to helping populations in underinvested areas overcome barriers to health. Marti has developed multiple programs for older adults and care partners, including Club Memory, Final Affairs Project, and the Laugh Cafe. She's a certified senior advisor, a certified dementia practitioner, and a certified Alzheimer's and dementia care trainer. Marti has a BS in Business Administration from Regis University, and clearly she's very qualified to talk to us today about this important topic to our community. So Marti, thank you for being here. Take it away.
Thank you so very much. I appreciate your kind words, Kathleen, and thank you to Friendship Heights Neighbors Network for inviting me today. I'm so very grateful. I'm going to show my screen now, and we'll get right into it. As Louise was saying earlier, as you have questions, if you would put them in the chat, that would be great. And please feel free to do it. And then periodically I will check the chat and see where we are. So today's topic is, what is dementia and what diseases cause it? So we're going to start with just a comment here about our objectives, what we're going to do. We're going to talk about what normal aging is. There are some things that are really things that we all face when we age, and we want to be able to differentiate those things, the normal aging, from the things that would be impaired or considered impaired brain aging. And so we'll talk about what those brain changes might look like and kind of the different levels of brain changes. And we're going to discuss primary diseases. There are more than 100 diseases that are known to cause dementia-like symptoms. So we're going to hit the top 4 or 5 and talk about what the key symptomology might be. You know, what could you expect if a person has these particular symptoms? And then we'll discuss ideas for what we can do to care for ourselves, or if we're caring for others, not only ourselves, but others. So let's talk first about age-related changes. In age-related changes, there's no cognitive impairment. These are things that happen to all of us. The truth is, I think we're all of a certain age here today. even though I'm not able to see all of you while I've got my screen up. We're all of a certain age, but I will tell you that we sort of hit our peak in terms of the speed of our recall and our retrieval when we were around 30 years old, 25 to 30. So we have been on a very slow but very steady, I'll say, decline in the speed of our recall. So it doesn't mean we don't recall. It simply means it takes longer for us to do that. I like to refer to, and I think most of us remember what a Rolodex is. I like to refer to the Rolodex as a metaphor. And the Rolodex, when we first get a Rolodex, we have very few cards in it. We add cards over time. But, as we grow older, as, each year passes, we have more and more data that we put inside our brain. And just as when we've got our Rolodex full, we might have 20 or 30 cards, or in the case of a brain, many thousands and thousands of cards, or even millions of cards to go through. It sometimes takes a bit of time to go through that. Now, that is all a metaphor. It's just to help us understand what some of the reasoning is behind our slower recall. But we also sometimes have slower decision making as well. All of us have a thinning prefrontal cortex. That's where we make our decisions. It's found really in the front of the brain, and it's where our executive function, our planning resides, our ability to manage things. All of those are happening in our prefrontal cortex, and that commonly thins as we age. We also have changes in the brain's blood vessels. We have something called small vessel disease that is very common in aging. Some people have more than others, but we almost always have small vessel disease as we age. They call it disease, but pretty much it's, everyone has it. We have a reduced inability to inhibit, or I'm sorry, an increased inability or reduced ability to inhibit irrelevant information. So while we might have been really great when we were in college or in high school, and we were doing our homework and listening to music and maybe drumming with our fingers, and we had all these things going on, and we could inhibit everything that we didn't need to be able to do our homework. Whereas now, perhaps when we're doing our taxes or something like that, maybe we can't have the TV or the radio or our music on. Maybe we can't have somebody talking in the background. Maybe we have more of a difficult time now shielding ourselves from that irrelevant information while we concentrate. Sometimes we are more easily distracted as well. And that's part of this whole inhibiting irrelevant information issue. We also have some reduced inhibitory control, which means we sometimes aren't as diplomatic as we have been perhaps in the past. That doesn't mean we are not capable of diplomacy. It means we have to work extra hard at it because the parts of our brain that control inhibition are less active in our aging years. And we also have some diminished spatial orientation, which means, as we're walking around the house, we may not be paying attention, and we may graze the corner of the door as we go over the threshold between one room and another. We just have some diminished spatial orientation. That does not mean the kind of spatial orientation that portends a more serious cognitive change, but there is a little bit of spatial orientation change. So I want to talk about the continuum of changes. And this is really important because I think a lot of us, I'm just going to be very blunt, most of us fear cognitive changes. So it's good to know that some of these things are normal. They're absolutely normal. Subjective cognitive impairment, though, is a little bit more than just standard aging. It's that I experience changes, but maybe no one else in my world does. And nothing appears on a cognition testing instrument. It's very early in any change, and it's just something I'm noticing, but no one else seems to notice. It is a good point at this time, and you'll hear me say this a few times in our session today, that it is if you have concerns about your cognition, it absolutely is a good thing to talk to your primary care physician about. If you do talk to your primary care physician might do one of several different instruments that suss out whether or not the issues that you are having are more than common aging or normal aging. If they are at a certain place in changes, your physician may diagnose you or your loved one with mild cognitive impairment, or MCI. Now, I want to point out that MCI does not mean you're going to get something else. In fact, only 1 in 6 go on to have more serious troubles. So there are many things that a person might be able to do to change things, to improve their cognition, to make sure that you're not one of the 1 in 6. And so we'll talk briefly at the end about some of the things that a person might do to reduce their risk. So those are the first two, but I want to talk about dementia. Dementia is an umbrella term. A lot of times people use it as a diagnosis, but it really refers to a group of symptoms. As I mentioned earlier, many experts say that over 100 diseases contribute to the group of symptoms that we refer to as dementia. There are plenty of things that might cause dementia, and others might be reversible. Some vitamin insufficiencies, for example, are reversible. For example, B12 is a common vitamin insufficiency that might cause someone to have some challenges with their memory. In fact, that has happened to me before, and I had to have some help getting my B12 up to where I was asymptomatic. Another thing, practically the whole country has got a D3 deficiency, but more significant D3 vitamin problems also can be a reason that somebody might have some mild cognitive impairment. And then COVID changes. You've heard, in fact, there have been several articles about long COVID recently, and sometimes COVID will last a little while longer, and you might have brain fog or COVID-related brain changes. Many times those COVID changes do resolve. Sometimes they extend for much longer. But always, I'm going to say it again, always see your physician if you are concerned. Be sure to have your Medicare annual physical, which now includes a baseline mini mental status exam, or MOCA, which is a Montreal Cognitive Assessment. And so if you have Medicare, if you're old enough today, on today's group, if you're old enough to have Medicare, then you are eligible for a baseline cognitive review at your Medicare annual physical. So mild cognitive impairment is not a euphemism for dementia. Thank you for bringing that up, Linda. It is not a euphemism for dementia. Only 1 in 6 go on to develop a progressive disease. So thank you for that question. It's a very good question. And then next. So here are some dementia symptoms in particular that we want to talk about. Sometimes it is memory. And by memory, I'm not talking about I forget somebody's name, and I've always forgotten people's names, but memory more like, people are talking to me about saying the same story over and over, or asking the same questions over and over. That would be a symptom that would be concerning. If I'm struggling with my thinking or my judgment, for example, somebody has called and said that I am an African princess, and if I just send them my credit card number, they will be able to get me access to my riches. Those kinds of things where thinking and judgment are a problem. And I've personally known people who have lost hundreds of thousands of dollars to such a scam when they were having symptoms like this, more serious symptoms. Another big concern with dementia symptoms are social changes. Often when language becomes a problem, which I'll discuss in a few minutes about certain types of dementia-causing illnesses, cause us to have language issues. And sometimes that can cause people to withdraw because they have a harder time keeping up with conversations. And so they might actually withdraw rather than struggle. And so when you have a friend that seems to be withdrawing significantly, it would be really good to find out, if you can, what is going on with them, and to see if they'll talk to you about how you might be able to support them. Serious spatial changes. I on Sunday was at a grocery store, and as I walked by a vehicle, I would have bet a significant amount of money that the vehicle I saw was owned by somebody, or at least driven by someone that has got dementia symptoms, and more serious ones. And that is because more serious symptoms cause people to have a lot of very small, they can be large, but often little fender benders. I saw this this Toyota RAV4 that had I'll say about 15 minor injuries, scrapes and bangs, and it was significant, and that indicated to me that the person, it was clearly not from just one scrape. It was an ongoing problem. And that is when essentially where I perceive that my car is and where other things are not compatible with one another, but I no longer, my visual field has changed to the point where it looks like everything is okay to me, but it is not. Also, new problems with words and speaking. I mentioned that before, that with the social changes, that the problems with words and speaking, I'm not talking about the tip of the tongue situation. We all, and this is totally normal, there are teenagers that have the tip of the tongue situation. So if you occasionally have a tip of the tongue, you've got something, a word right on the tip of your tongue, and you can't get to it right away, that that is not what I'm talking about here, but new problems with words and speaking where I have my hearing intact and I'm still not able to understand what somebody's saying, or I'm unable to make myself understood. And I have problems with finding words that are really common. For example, I'll use the word toothbrush. We might say, if you're having really significant problems, a person might say, that stick that you put in your mouth and you put something on it, you put it in your mouth, and it's supposed to help you clean those things that are in your mouth. So I didn't say much, but after a minute, people are going to say stick. Oh, toothbrush. And those are the kinds of difficulties with expressive language that I want to refer to as a more concerning issue. And then personality changes. I personally had an adoptive father who was not a nice guy. There are harsher words that I could use to describe him, but I'll just say he was often mean. And when he was diagnosed with Alzheimer's, he became the sweetest, kindest, most gentle person you might ever know. And the reverse can happen, that someone who's kind and sweet and thoughtful might have a personality change that is significantly just unexpected, with explosive rage or anger, that sort of thing. So those are also, personality changes are also symptoms that would lead us to think that a person might have a more serious problem. My thanks to the Alzheimer's Association. And I would also say that alz.org is a great website for people to go to get all kinds of information about not just the Alzheimer's form of dementia, but Alzheimer's disease and related dementias. So I'm going to very quickly go through the major risk factors for dementia. The age from 60 to 64, the risk is really small, but the risk doubles every 5 years after the age of 65, and after 85, the Alzheimer's Association says, and NIH say the risk is almost 33%. 1 in 3 will have Alzheimer's. There are family history genes, but I want to be so clear that if you have somebody, a first-degree relative, that means a parent, one of your parents in particular, or some sibling would be first-degree relatives. If you have a first-degree relative that has Alzheimer's or had Alzheimer's, it says that you have a risk, but it is not deterministic. So it is only one of the risks. And there are Ancestry, for example, Ancestry Health and 23andMe both have tests that you can take. You can also get this with your physician if you really want to know if you have 1 or 2 copies of this APO3 allele. Then you can have tests done to tell yourself. My husband and I both did have the test because we both wanted to know. And in terms of deterministic genes, less than 1% of all people have a deterministic gene. What do I mean by that? There is a particular family, and many of you may have seen a documentary. I don't recall what the name of the documentary is, but there's a family in Colombia that has this deterministic gene, and every single person gets it. That is a really, really small percentage, less than 1%, number one. And number two, typically if a person has a deterministic gene, the expression of that deterministic gene happens much earlier than normal age-related risk factors. So, for example, you would be seeing changes in 40s and 50s, but certainly if you're 60 and over, it's very unlikely that you have a deterministic gene that's causing your problems. Other risk factors, if you've had significant head injuries, if you've had falls, if you've had, if you were beaten, if you had a head injury as a result of war. Head injuries are a big cause, and particularly concussion or traumatic brain injuries specifically. That does cause me to meddle a little bit and say, if you're riding bikes, please make sure, when some of us were young, we rode bikes and we never wore a helmet, but please make sure your head is protected when you're doing either biking or skating or anything where it's not just you and your feet and your shoes that are attached, connected to the ground. So also risk factors, overall poor health, specifically, and so many people do not know, high blood pressure, untreated high blood pressure is a huge risk factor for Alzheimer's type and for also vascular dementia. So please, a lot of people get diagnosed with high blood pressure, they're given a blood pressure medication, but they don't take it. And so I want to make sure that if you are being treated for that, that you do know that that is a risk factor. Diabetes is a risk factor. In particular, I'll say uncontrolled diabetes. So if you have diabetes, please make sure that it's in good control. High cholesterol is also a risk factor, in particular for vascular dementia, and also diabetes would be vascular, but also has been associated with some Alzheimer's as well. Stress is a risk factor. If you have got chronic, relentless stress, do everything you can to relieve yourself of stress, particularly chronic stress. There are many things that do cause chronic stress. I could do a whole presentation just on risk factors, and the efforts a person might make to mitigate those. If you have a sensory handicap, if you have vision issues, please correct your vision. If you've got hearing, my colleague Frank Lynn of Johns Hopkins just finished publishing an extraordinary long study on the sensory handicap. Over 10 years ago, he had completed one that demonstrated that people with hearing impairments were 15% more likely to have dementia. But what he didn't know was what happened if you treated the hearing loss with hearing aids. And over the last 10 years, he has done extensive study, and he now found that you can reduce your risk by 37% if you are willing to get and wear hearing aids to make yourself able to hear and have that input into your brain and reduce your sensory handicap. Also, poor sleep is a risk factor and a significant one. Again, all of these things are things we could do an entire presentation on. Thanks to NIH for these, because while this is not a complete list, these are the primary things we would expect to have high on the list. So I'm going to look at the chat really quickly. Dementia is not the same as Alzheimer's. Alzheimer's is a disease that causes dementia symptoms. So that's a great question. So if a person doesn't have a diagnosis that is specified, often people will have a diagnosis that says dementia NOS, dementia not otherwise specified. And so it could be any one of those 100 illnesses that I was talking about earlier. And I'm getting ready to talk about the 5 most common. But dementia does not equal Alzheimer's. Alzheimer's is simply the most common form of or common disease that causes dementia. Probably some people say as much as 40%, other people say 30 to 40% of people with significant dementia symptoms have the disease of Alzheimer's as the root cause. Hopefully that's helpful. And thank you if I misspoke and said that dementia equals Alzheimer's. So if you look at this at the top, diseases that cause dementia, Alzheimer's is the most common. It's characterized by memory retrieval issues. A lot of people say memory loss, but there are all kinds of reasons why we have come to understand that the memories aren't really lost, but people have a more difficult time retrieving them, or may be completely unable to retrieve them. In particular, short-term memory. So when we have short-term memory issues, that is a common symptom of Alzheimer's. Poor judgment leading to bad decisions is another symptom. Sometimes people have a loss of spontaneity and a sense of initiative, like motivation is lacking. People might be generally apathetic.
Mute. It
I beg your
goes
pardon?
to mute.
Okay. So, people can be like very apathetic. They never want to do anything anymore. They have an entire loss of motivation. And when you see, if somebody's always sort of lacked motivation and you lack more motivation, then that's less of a concern than someone who has been type A, highly motivated, loves spontaneity, loves adventure. And what you're seeing now is the complete opposite. Also, losing track of dates or knowing where they are. That's a symptom of Alzheimer's form. Taking longer to complete normal daily tasks. I had somebody that I was acquainted with many years ago who worked for a government agency and had gotten a performance corrective action because instead of doing things that they'd always done at the same speed, they were doing things at about a quarter of the speed. So their productivity had significantly reduced. And that notification led the person to reach out to a physician and say what had happened. And they'd been previously unaware that it was taking longer. And so as a result, they were able to get a diagnosis of Alzheimer's from their boss saying, listen, this is not okay. You're just, you're not able to do the job anymore the way that you used to. And then also repeating questions or forgetting recently learned information. By repeating questions, I'm like going, I'm not talking about, are we there yet? Which is what your kids do, your kids used to do when you're on vacation, or your nieces and nephews, or that sort of thing. I'm talking about asking the same question over and over, like, excuse me, I need a drink. Like, what time is the doctor's appointment? And then 10 minutes later, what time is the doctor's appointment? Or forgetting recently learned information. I'm not, in this case, talking about, I beg your pardon, I'm going to have to go on mute just a second because I have to cough. One moment. Okay. So by recently learned information, I'm not talking about, I just learned somebody's name and then I forgot it. Because we're a bit more easily distracted as we get older, we want to make sure if we're judging a recently learned information that we actually did learn it and that we didn't get distracted somehow in the middle of learning it. So for example,
And that one, it pressed it to mute.
let's say, let's say Kathleen and I are somewhere and somebody introduced themselves to me, and at the same time, Kathleen is giving me some information. I might not get either one of those things because I had some interruption to my learning. So just know that forgetting recently learned information is a common thing if you get distracted. So let's talk about frontotemporal dementia, also fairly common. It's often diagnosed in younger years, sometimes as early as 40 or 40, 50. And it has memory changes, but usually not at the beginning. Often it's behavior changes. There was an amazing article in the Washington Post magazine that dates me a little bit that talked about somebody that had been discharged from their job because they were found accessing pornography on their computer in front of other people even. And it was a serious judgment problem. But also what it led to diagnosis because, and he got fired for it, but it led to a diagnosis because his wife said, "This is not my husband. There's no way my husband did this." And so she was on a mission to find out what could have caused it. And ultimately that gentleman was diagnosed with frontotemporal dementia. Impulsivity is often a behavior change. So sorry, I have a terrible tickle. Also, problems with speech are more common, both receptive or language that we get in. So if you speak to me, I'm receiving the language. So I might have trouble understanding you. And expressive, meaning that I know what I want to say, but I may have difficulty saying it. And so these are much more common symptoms of this type of dementia causing illness. Vascular dementia, these are also progressive and irreversible diseases, these particular ones that I'm mentioning. Vascular dementia is typically a result of a stroke. It's very common, but it can be, and what we see that are some of those issues. We talked about high blood pressure and high cholesterol being an issue, or diabetes. All of those issues might lead to vascular dementia. There are also huge stroke risks. So you might have confusion or disorientation. Again, when a person has had a stroke, their Broca's region might be impacted and they might have trouble speaking or understanding speech depending on where the stroke took place. They might have physical stroke symptoms such as a sudden headache, difficulty walking or poor balance, and then numbness or paralysis on one side of the face or the body. If you don't know what the symptoms are of a stroke, it would be so good for you to learn them. But if a person that you're talking with all of a sudden seems to have a change in their smile, you might ask them, can you smile for me? And if both sides of their mouth don't go up, or ask them if they can hold both arms out. If they have trouble speaking, that's a 911 call, just to be very clear. Time is of the essence. It's really important. Okay, Lewy body dementia. This is also, Lewy body is a common, fairly common dementia, disease that causes dementia. They do call it Lewy body dementia. So while it's not equal to the disease, it's common parlance to say it. So you have changes in thinking and reasoning. So like prefrontal for sure, but also fluctuating cognition sometimes that is like delirium. It's almost like somebody has a really a high a fever almost. They can be fine, and then a few minutes later might have like really serious cognition issues. They also have well-formed visual hallucinations. For example, I've had someone say to me, where is the dog? And I, you know, like I'm in the hospital and there's no dog in the hospital or the hospital room at the moment, right? And so I would say, do you mean your dog? No, not my dog. It wasn't my dog. I don't have a dog. But where's the dog? Or it might be, you know, 5 people came in to see me, you know, and I was like, when did that happen? I'm thinking that, but the person had really well-formed visual hallucinations. It's not usually useful to correct someone who's having a visual hallucination, to be very clear. Saying they're not here is not useful. Getting into their reality and say, well, hopefully they won't be back. Or did you enjoy their visit? You know, or something like that to get them to talking, but not to say they weren't here. REM sleep behavior disorder, that can cause people to actually act out their dreams. It can also cause night terrors, and that can be really very unsettling for both a person that has Lewy body disease and also anybody who's living with them. Also, sometimes there is Parkinsonism with a slowness of movement, tremors or rigidity. And then the person can also have delusions, you know, that might say, I'm working for the CIA, or although around here, you know, maybe they did work for the CIA, but or they might say, you know, something like, I invented the automobile. That would be a delusion, and an obvious delusion, right? So Parkinson's dementia and Lewy body dementia are often very similar, but a person can have Lewy body without having Parkinson's disease. And not everybody with Parkinson's disease has Parkinson's dementia. So, or those changes over time, they may have some of the symptoms, but they may not have all. So what is the difference with Parkinson's? You might have changes in memory, concentration, and judgment, but you're most likely to have problems with concentration and judgment. Trouble interpreting visual information. This is also often true for Alzheimer's type. Can have muffled speech. It may be very or very low speech, so that the person is so soft, it's very difficult to hear them. That also is a often an issue with there's treatment for some of those low volume speech issues. Visual hallucinations are sometimes possible, also delusions, especially paranoid ones, and depression, some apathy, irritability, and anxiety. And then again, not everybody has all of these symptoms. And if you've seen one case, this really, I can't say it enough. If you've seen one case of any of these, you've seen one case. So just because I say these are symptoms, it doesn't mean that everybody who has a diagnosis is going to have all those symptoms. They may have all of them. They may have only a few of them. And some of them are worse than others in, you might have really significant visual hallucinations, but have no problem with memory. So just know that there's a lot of sleep disturbance also with Parkinson's, like there is with Lewy body. So I'm gonna stop here and just check to see if we have any questions. Okay, no. All right, let's talk about what is possibly protective. I mentioned earlier that you have an opportunity with Medicare's annual physical to get a baseline cognitive function test. It's pretty important that whoever you get your annual physical with, that you get that with the same person each year, or make sure your chart gets transferred so that if you do change physicians, that your second year physician knows what the first year baseline was, so they can determine if there have been any changes for you. Why is that protective? Early diagnosis is helpful, as we don't have any great treatments for so many of these things, but what we do know is that there's some basic things that are best to do when you're very early in a stage of cognitive change, that are best done then. And so getting a diagnosis and knowing your diagnosis is really helpful to getting those things done. Specifically, and I'll meddle a little bit right now, but if you don't have an advance directive, if you don't have a power of attorney for healthcare and finances, it's a very good thing to do that. If you have one and it's been more than 5 years since you have looked at it, then it really is important. Most lawyers say, especially elder law attorneys, say that you should be looking at these every 5 years, mostly because your thoughts may change, but also laws change. And so you want your attorney to take a look at that. And then also, if you've moved, if you were in DC and now you're in Maryland, different jurisdictions have different laws. So you want to make sure that while you have your best cognition, that you are making decisions that are going to impact you in the long term. And that's only one of many reasons. Also, what is protective is novelty, doing things different, doing different things and doing things you do regularly differently. So for example, what makes eating novel? Well, I do it multiple times a day. So what could possibly make that novel? What might make that novel is eating one meal a day with my non-dominant hand. If I do it with my non-dominant hand, you will actually feel your brain saying, hey, what are you doing there? Now, clearly, I'm not deluded. I'm not hallucinating. I don't actually think your brain is saying that, but you can feel just just a second of confusion as your brain gets around the fact that you are not using your dominant hand, or, it really does. You can actually feel when you're doing things a little bit differently. Greater education is also protective. One of the things we know is that people with advanced degrees have lower incidences of, in particular, of Alzheimer's disease. And so getting education, keeping your mind active, learning new things. And specifically, there have been some studies that showed that learning a new language or learning a new musical instrument are things that create a lot of new neural connections. It's protective to watch your numbers and your overall health. So do get your annual physical. Make sure that you're looking at your numbers and following your physician's advice. Maintain and closely nurture your emotional support and social networks. This might be a community of faith. It might be a club. It might be your neighborhood. It might be the village, being involved in the village activities and that sort of thing. But there is a significant cost to withdrawing and isolating yourself. I say isolation is the enemy of your brain. If you want to keep your cognitive health, stay connected. It's so important. Lots of research done on this. Be physically active. If you are a person that needs an assistive device and you use a wheelchair or you use a walker, then ask your physician to help you with a physical therapy assessment and find out what you could be doing to stay active within the limitations that you presently have. If you don't have very many limitations or you've talked to your doctor, then just getting any kind of moving your body is a good thing. Blood flow is good. So even if you're like right now, I'm going to encourage everybody here to do this with me. I'm going to take both hands and I'm going to take my right hand and lift up my left knee. And then I'm going to alternate this. Lift your knee and touch it with the opposite hand. Even seated, you can do something. You may not be able to do everything, but you can do something. So find out what it is you can do safely to stay physically active. Also, look for opportunities for good sleep. If you or somebody that you share a bed with are not a good sleeper, then whoever's not a good sleeper is causing the other person to not be a good sleeper also. So make sure that you get a sleep assessment. And if one of the person's a snorer, they might have obstructive sleep apnea. It's not good for their heart or their brain. And the snoring might keep the non-snoring partner awake. So know that good sleep is crucial. It's vital to your brain. While we sleep, so many things get done while we sleep by our brain. One of the things the brain does, and this is totally lay terms, these are not clinical terms, but essentially your brain repairs things. It takes out the trash, what it doesn't any longer need. It recycles the things that can be reused. And, it repairs like tiny little micro tears if you've worked out or something. It does so much. And when you don't get good sleep, you don't get the benefit of all of the things that happen during those different stages of sleep. Also, healthy eating. And I'm not saying that you can't have this or that. Please hear me say that occasional use of something that gives you great pleasure can be very pleasant. But you don't want to be eating them all the time. So, for example, I happen to love strawberry shortcake, but I don't just love strawberry shortcake. I love strawberry shortcake with a healthy amount of whipped cream. I do not normally eat that but once a year, and I want it for my birthday. And so if we're going to be eating things that aren't good for us, or carrot cake, I also love carrot cake. Just don't eat it all the time. The two diets that are most commonly recommended by the Memory and Alzheimer Treatment Center at Johns Hopkins is the Mediterranean diet, or are the Mediterranean diet and the MIND diet. Both of those that can be looked up online, and they're fairly easy to follow. So the Mediterranean diet and the MIND diet. And then also remember about safety. Do reduce your possibilities of head injuries by making sure that you cover your head if you're biking or skating or something like that, or you're doing, you're on an ATV, on some kind of special vacation. In addition, another thing that might help you be more safe is to reduce your risk of falls. So if you have been falling, please let your physician know that you have been falling and that you need a PT assessment, and they will give you some things to do to help reduce your risk of falling. Falls are a huge risk for a head injury, and we know that head injuries are risk factors for Alzheimer's disease. So if you are concerned, let's talk about you are concerned. And I know I've said this stuff a lot, but this first thing, if you're concerned about your memory or cognitive function, make a list of all the things that you're concerned about. Are people complaining you are repeating yourself? Are you having bills that are coming to you and you have late charges, or you've gotten your utilities turned off or something like that? If you're struggling to do familiar things, if you are the host or the hostess with the mostest and you cannot seem to put together a dinner party or a recipe that you've used your entire life and never really needed it, the card for, you can no longer make that recipe anymore, then make an appointment with your primary care physician. And don't wait. I mean, really, if you are concerned, please tell them you're concerned. And then because they can do a battery of tests to rule out the problems that we talked about early on that are reversible. Reversible causes of especially subjective cognitive issues. And so what they might do blood work, workup, a complete blood count, and also check your vitamins, the key vitamins, to rule out any other problems. And they would also check your thyroid. Hypothyroid is a common issue with having issues with reversible cognitive changes. So do have some tests, give your physician an opportunity to rule out these other problems. So, like, we're already here. I'm wondering if, Louise, would it be okay if we opened it up? I'm usually used to people being able to speak. So I'd
Yep.
love it. I'd love it if you, oh, I'm seeing that my sunglasses are my transitions are coming on because I've got a lot of sun on my face right now.
So if you
we
want to unmute yourself, or if you're
Yes,
more comfortable putting questions in the chat, that's fine too.
either way is fine, but I'd love for you to be able to ask your questions.
Here's a question in the chat.
Okay, yeah, I'm gonna display the last slide again, just a second. Okay. So let me answer these questions really quickly. So Club Memory is a stigma-free community program that Sibley started. Actually, I started 12 years ago, and we started with 10 people in the Sibley cafeteria. We now serve, we've been all the way up to 1,000. We have around 600 or 700 right now. Things happened a lot during COVID, but we serve people that have some diagnosis, either mild cognitive impairment or another disease that is cognition impairing. We serve in care pairs, which is, what do we mean by that? That means both the person with the diagnosis and the person who is their care partner come to our program. And there are all kinds of reasons that happens, that we can speak with you privately about that. But we have support groups for the person with the cognitive changes, as well as the person that's a care partner. And then we have games and activities that are, people determine what they want to do, and then they do the things. We have lots of different things going on. And then we have both in-person and Zoom options as well. So there's that. And then how can we help a parent who does not recognize his dementia and who gets angry? Well, I think that one of the things I would do is, the first thing I would do to help a parent who is in this situation is to get in a support group myself, is to get into a care partner support group, because having skills to cope with the problems related to dementia symptoms, having those skills, there's no substitute for it. And one of the most important things is to not try to orient the person to the current reality. But no matter what type of cognitive changes they have, reorienting them to the reality is, that's one thing that causes people to get angry. Also, another thing that causes people to get angry is when we try to take their independence. And so this again could be, this one thing could be a whole presentation. We have a program too that we have called Dealing with Dementia, which is for care partners. It's really good training that was put together by the Rosalind Carter Institute on Caregiving. And so we've got lots of options to help people get trained who need help with their loved one that's got cognitive changes. And then let's see, what is the expectancy if diagnosed with advanced Alzheimer's? That, remember I said, if you've seen one case, you've seen one case. Some people say 4 years. and I personally have known someone who had a diagnosis and lived nearly 20 years. So many people have called it the long goodbye. But if somebody has got advanced Alzheimer's, I kind of would need to know what symptoms qualify as advanced to be able to say what that looks like. Where can one find good studies on what causes Alzheimer's? Well, that is a really good question. And PubMed, NIH has a lot of studies on this, but truthfully, we don't know really definitively what causes Alzheimer's. We honestly don't know what causes a lot of these chronic is not the right word I want. See, I had a word finding change there, but I knew that it wasn't the word I was looking for, right? When something is progressive and irreversible, we don't necessarily know what causes all of them. There are some things we do know. We know that having a closed head injury can cause as a huge risk for Alzheimer's, or CTE, which is the brain dysfunction that is found in so many football players that have Alzheimer's. Actually, it's not Alzheimer's disease, it is CTE, but the symptoms are, it's also progressive and incurable. So we just don't know what causes everything at this point. Knowing what causes everything would be super helpful to finding a cure. So I saw that Alan says, my sister with Alzheimer's keeps calling me and saying her husband has been fooling around and left her. And so, Alan, what I would say the best thing to do in that sort of situation is just to say, oh my gosh, I am so sorry. How can I help? Don't say he passed 20 years ago, because that causes a lot of grief, and you would have to chronically tell her he passed 20 years ago, because if she has Alzheimer's, she's not going to remember that you told her this. So just telling her, how can I help, and being sympathetic and compassionate is a better solution than and just getting more information from her. Yeah, I would not say that he passed. I would say, how can I help? You want me to give him a good talking to? I mean, anything that she thinks might be helpful, then you just say, I will be happy to do that. And so the best way to keep her from getting more upset, though, is to get in her reality. Let's see, how often over medication causes cognitive problems? Okay, so polypharmacy is certainly a problem. Substance use disorder, which would be something like alcoholism or chronic use of medications that are scheduled medications that are tightly controlled access. Those can cause cognitive problems. In fact, there's a separate disease that's called Wernicke-Korsakoff's syndrome, that is essentially what happens when people are alcoholic and have that kind of syndrome, or have cognitive changes as a result of alcoholism. So, but it does not necessarily cause ongoing cognitive problems. What it might cause is You do want to have your polypharmacy looked at to see if I have medication interactions that are causing challenges that may be causing me to be distracted or forgetful or whatever. Those things, same things often make you a fall risk also. So periodically, there are different organizations that might do medication reconciliations. And so, and your own pharmacy might be willing to do that for you. They should be looking at them every time you have a prescription. And as a result, I would highly advise that you get your prescriptions filled at the same pharmacy so that the pharmacist has a list of all of your current medications, because that will pop for them to show them it is, not recommended or contraindicated when you are taking XYZ. So using the same pharmacy will help that, and having a medication reconciliation would be important also. If you want to talk to your doctor, I would highly recommend you do a separate appointment for a medication review, because it does take it takes a while. So you want to have them set a separate appointment. And I'll say in general, when you go and you have like 13 things on your list, that can be really challenging. So you want to talk about the most critical items first and kind of make sure that you get those taken care of first. That was a really good question. Thank you so much. These are all excellent questions. If somebody with dementia doesn't want to lose their independence, how can we stop them driving? Okay, this is one of the hardest things ever. And your physician can also help you with this, because sometimes if you call the physician, if you've got a release, and your person, I'll just use my situation as an example. My dad got diagnosed with Alzheimer's, but it was in fairly early stage. However, what we were seeing is that he had saved back some medication. And so he had Alzheimer's, and he was sort of medicating himself with stuff that he had left over that he technically wasn't on his list anymore. And so we wanted him to stop driving because he just really wasn't safe anymore. So what we did was ask the physician to talk with him, and the physician basically said, you really can't drive anymore. It's not safe for you to drive for these reasons. And he fought with them and with the physician, and the physician made a deal with them, and he said, how about we get a driving assessment by a qualified person? And would you agree that if somebody who's expert in assessing your driving says that you can no longer drive, would you agree that you shouldn't drive anymore? And indeed, that is what happened. We got the driving assessment. The driving assessor said you should not be driving, and he did follow those rules. So it was his own decision at that point, because he had agreed with the doctor that if he got the assessment, he would do it. So nobody wants to lose independence, but it's really important. Nobody also wants to be responsible for killing someone because they drove up on the sidewalk when they got distracted. So just know that it is something that you need to tackle, but also with your physician or with the person's physician. Is there a correlation between sleeping medications and Alzheimer's? Without knowing what the sleeping medications are, I can't really fully answer that, but I would say anytime we are using medications that change our sleep architecture, and that it really depends on what the sleep medication is, because some things have been used since time immemorial and it looks like they're fairly safe. So it really depends on that. There can be a correlation. And in particular, there are a number of medications that are black boxed for older adults. As you might be taking a medication that you have taken for 15 or 20 years, but because your kidneys are not clearing things necessarily the way that they always did before, you may be more susceptible to the medication than you used to be. So talking it over with a physician about your medications are certainly, it's certainly something everybody should be doing, particularly if you've been taking sleeping medications, anti-anxiety medications, that sort of thing for a long time. You want to ask your physician, is this something that I should be concerned about? Are there any newer medications that are less concerning? So, good question. How can we correct a paranoid destructive statement if not able to present the reality of the matter? So I actually know this problem a lot because I've been in this situation a lot, where I have somebody in my family that has got the same issue. And sometimes they understand that they're paranoid and sometimes they don't. But the more you try to correct the paranoia, the more the person thinks that you're part of the thing to be paranoid about. So it again is better to just say, I am so sorry. That must be so hard to feel that way right now. You don't say it's the truth. You just say, these feelings are so hard. And I'm so sorry you're feeling that way. That stings. And so there are other ways to interact with that, but just know that, and I have to tell you, I am not the queen of I do not have all the answers. I'm doing the very best I can to field the questions that you have, but just know that these are things that are often trial and error kind of things, because what might work with one person doesn't work with someone else. And so it's really important to try it and see what happens. And then if you get a negative response, then you might come back again and say, maybe I need to try a different tack with this. Also, again, if you've got somebody in your, if you've got someone in your sphere of influence that is dealing with a cognition problem that is irreversible and progressive, like Alzheimer's, like Lewy body or whatever, it really is significantly important to get involved in a support group so that you can ask these questions and talk to other care partners to find out how they tackle the issues. That's one of the best reasons to get involved with other care partners, is to talk about these issues. So, I think I've tackled most everything. Let's go ahead and stop sharing. I just thank everybody for coming today, and I'm gonna stop the recording, or whomever is doing that can stop the recording.